So today I'll be talking about autism and some of the recent updates in the field. As you know, the DSM-5 came out with new diagnostic criteria. And also there's some update in the clinical guidelines. So to get started, I do not have any financial disclosures, and I'm not a member of any of the organizations that I'll be talking about today. So how do you define autism? So autism spectrum disorder is a pervasive developmental disorder. It is phenotypically heterogeneous group of neurodevelopmental syndromes with polygenic heritability. It is characterized by a wide range of impairments in social communication and repetitive and restricted behaviors. For some of you in the audience who are familiar with DSM-3 and DSM-4, it was previously under the title of infantile autism, autistic disorder, Rett syndrome, PDD, NOS, childhood disintegrative, and Asperger's disorder. With DSM-5, it has all now been combined under one umbrella of autism spectrum disorder. So a little on the history of autism. The Austrian-American psychiatrist Dr. Leo Kanner was the first person to coin the term infantile autism in 1943. And he wrote a paper, The Autistic Disturbances of Affective Contact, in that same year. He described about 11 children who were withdrawn, had deviant language, repetitive behaviors. They were socially awkward and also had poor eye contact. He hypothesized that the rate for autism was actually much higher than what we were seeing at the time, possibly due to misdiagnosis of intellectual disability or childhood schizophrenia. Subsequent to his work, it first appeared in the DSM-3 as an official diagnosis in 1980. So what about the epidemiology of autism? There's been a lot of talk about the increasing prevalence. So we know that it is 4 times more common in males. It is most commonly seen in the Caucasian race, less commonly seen in African Americans, and least commonly seen in Hispanics. Different studies have suggested a different prevalence rate, anywhere from 0.7 to 72 for every 10,000 children. The median prevalence has been calculated to be 13 in every 10,000 children. And although we have all this data, the current estimated prevalence is 1 in every 68 children. And so you might be wondering why this difference, and I wanted to help explain that. So this is a table that I took from the CDC website. It's basically a table showing the current and previous prevalence rate of autism. The CDC had started the Autism and Developmental Disabilities Monitoring Network in 2000. And what they did is, based on which states they got funding from, they went back to those states, to the schools, saw which children were in special educational services and which children were having a concurrent diagnosis of ASD. And so based on that, they came up with the prevalence rate. So you can see that for the year 2000, they came up with a prevalence rate of 1 in 150. Then for the year of 2010, they came up with a rate of 1 in every 68 children. So there have been a few theories as to why we're seeing this increased rate. The first one is diagnostic substitution. Prior to the 1990s, autistic disorder did not qualify a child to receive special educational services. But with the advent of the Individuals with Disabilities Education Act, children were now qualified to receive services even with the diagnosis of autism. And so possibly clinicians were giving the diagnosis of autism more frequently than either intellectual disability or other learning disorders, and so we term this as diagnostic substitution. Also, labeling biases, using less rigorous criteria, also educational funding trends, and parents even advocating for children to have the diagnosis so that they qualify for services. Later on in the 1990s, the federal and state government facilitated closures of institutions. They wanted families to be able to raise their disabled children at home. And so these children that were previously in institutions were now being counted, quote unquote, in the educational prevalence data. And so this could also be another explanation. Lastly, with the research that's been going on in autism, we know that there are some genetic syndromes that manifest with a concurrent ASD, and so that could also possibly explain the increased prevalence. So what causes autism? We know that there are multiple genes involved. We know that chromosome 2, 7, 16, and 17 have shown some abnormalities. Also, maternally derived chromosome 15q duplications have been found. 80% of female children diagnosed with Rett's have shown the mutation in the MECP2 gene. Also, genetic syndromes like Downs, Fragile X, and tuberous sclerosis have shown concurrent ASD. We also know that these children have an elevated platelet serotonin level, but we're not so sure how that plays out into the symptomatology. So you might be wondering where vaccines come into all of this. So there's quite a bit of history on that, and vaccines have been talked a lot about over the last 10 to 15 years in relation to autism. So back in 1998, there was the first article published in the British Medical Journal, and the writer suggested that MMR causes autism due to a persistent viral infection in the gut. And they termed this as autistic enterocolitis. Subsequently, this article was retracted, and there have been multiple studies to suggest otherwise. The Institute of Medicine, which is a nonprofit organization and reviews issues which are concerning public health, established the Immunization Review Committee in 2001, and their study came out with the following statement. Evidence favors the rejection of a causal relationship at the population level between the MMR vaccine and autistic spectrum disorder. There was a study in 2002 in Denmark. It was a retrospective cohort study with 500,000 children, and they could not find any causal association. In 2004, the CDC in Atlanta conducted a study with over 600 children, and they could not find any association between the onset of autism and the child having received vaccines. Again, there was a Japanese study comparing the risk of autism children who received the MMR versus those who received the single antigen measles vaccine, and they couldn't find any relationship there. And then lastly, there was also a Finnish study which had more than 500,000 children, and they could not say that there was an increased risk of acute neurological injury subsequent to following or leading to autism. So a lot of study has been done on the brain regions that are affected in autism. We know that for one, the amygdala, which is the emotional hub, has shown to have decreased neuronal size. The fusiform gyrus, which is responsible for face recognition, shows abnormal response on fMRI studies. Additionally, the superior temporal sulcus, responsible for nonverbal communication, has shown decreased activity. The prefrontal cortex, responsible for recognition and response to emotions, is also abnormally low functioning. Then the abnormal mirror neuron network studies have also suggested that there are some potential abnormalities with that in autism. So here's a diagram of the limbic system, and the area shaded in yellow, mainly the amygdala and the hippocampus, is where we think the majority of the pathology is with children with ASD. And here is an fMRI study. To your left, you'll see a healthy control. The area shaded in yellow and red and circled in red is the fusiform face area. That is activated when a child sees a human face. And then on the right, you have a child with autism that doesn't have any activation of that area upon the same stimuli. So what are the risk factors for autism. There are multiple risk factors. We know that one of them is increased maternal and paternal age, prenatal exposure to thalidomide, valproic acid, as well as alcohol, also known as fetal alcohol syndrome, perinatal complications like prematurity and birth trauma, the male sex, and also monozygotic twins. So they have a 60% increased risk, and siblings have a 7 to 10% risk. And the risk increases with the greater number of siblings that the child has that have already been diagnosed with ASD. So this brings us to the DSM-5 Diagnostic Criteria of Autism. What are you looking for in a child that would suggest autism? So under the category of neurodevelopmental disorders is autism spectrum disorder. The first criteria they require is persistent deficits in social communication and social interaction across multiple contexts as manifested by current or history of. And that would be social and emotional reciprocity. So look for a child that has limited social interactions. They don't respond to any interaction that's initiated, and they don't initiate any on their own. Also, you'll see a lack of social smile, and they have an abnormal theory of mind. So theory of mind is the ability of a person or an individual to infer the emotions and motivations of other people. And this has found to be lacking or abnormal in children with autism. The second thing we're looking for is deficits in non-verbal communicative behaviors. So they have abnormal eye contact, abnormal body language, and many times they lack facial expression. We're also looking for deficits in maintaining, developing, and understanding relationships. And so you can see how all this is tied in. When they have difficulty with nonverbal communicative behaviors and they don't initiate social interactions, they just don't develop and maintain relationships. They also have difficulty with adjusting their behavior to different social contexts, and they're not really interested in peers. So again, that just contributes to increased difficulty with relationships. So for this first criteria, you will have to specify the current severity level. According to DSM-5, you can have a severity level anywhere from level 1 to 3, level 1 being the least severe with the minimal amount of support required, and level 3 being the most severe with substantial support required. So the second criteria, restricted repetitive patterns of behaviors, interests, or activities as manifested by at least 2 of the following or by current presentation or history. And here you'll only need 2. So the first one is stereotyped or repetitive motor movements, and this can also be use of objects or even speech. So motor stereotypies or echolalia. The next thing we're looking for is insistence on sameness, inflexible adherence to routines, individualized patterns of behavior, and nonverbal behavior. So if you talk to a parent, they'll say they have a lot of difficulty in the morning, getting their kid ready for school or getting them to bed. So any sort of transition from one environment to another causes a lot of difficulty for these kids. The third thing we look for is highly restricted and fixated interests that are abnormal in intensity or focus. So you might find that the child carries the toy around. They're particularly interested in just one inanimate object. We also look for hyper and hyperreactivity sensory input. So they could be abnormally insensitive to pain or temperature, and then they're very sensitive to sounds or textures. So the touch of fabric, the texture of food, the smell of food, all of that is very important to them, and that again makes it difficult for parents. Again here for the second criteria, you only need 2 of the 4 we talked about, and you do have to specify the current severity level. The next requirement is that it has to present in the early developmental period. So according to DSM-4, it was between ages of 0 to 3 years that you should have seen the onset of symptoms. But according to DSM-5, it is now in the early developmental period, which is 0 to 8 years. It should also be clinically significant impairment in social, occupational, and other areas of functioning, and it cannot be better explained by intellectual or developmental delays. So the DSM-5 allows you to specify other comorbid conditions that can be important to the child's existing diagnosis of ASD. The first specifier is for intellectual impairment, also language impairment, any medical or genetic conditions, and so under this specifiers where you would classify REDs, also any neurodevelopmental or psychiatric conditions, and also the presence or absence of catatonia. And so this was the severity level that I had talked about earlier, level 1 requiring the least amount of support and level 3 requiring the most amount of support. So how is this existing diagnostic criteria different from DSM-4? So under DSM-4, they had a number of diagnoses: autistic disorder, Asperger's, REDS, childhood disintegrative, PDD, NOS, and all of that has been combined under one umbrella of autism spectrum disorder. The second difference is that the DSM-4 required disturbances in 3 different domains. The first domain was social relatedness, the second was communication and play, and the third was restricted interest and activities. So instead of the 3 domains, DSM-5 proposed just 2 domains, and they grouped the social relatedness and communication and play into one title, and then the second is restricted interest and activities. The third difference is the onset requirement. So DSM-4 required onset to be before the age of 3 years. This has now been changed to 0 to 8 years. You're also allowed to make note of sensory abnormalities in these children with the DSM-5. And lastly, you can also specify for intellectual disability, language impairment, medical and genetic conditions, and also environmental factors. And so the main advantage of DSM-5 is that if there is any other comorbid diagnosis, the clinician can include it, and so any other provider working with the child will be aware of this. So coming to comorbidities of autism, the most common comorbidity is intellectual disability. It is seen in 50% of children with, as severe, and another 35% have mild to moderate. The next is seizure disorder. So different studies have different prevalent rates for that, but it's anywhere from 8 to 25%. It is bimodal in distribution, meaning that it is more commonly seen in children from 0 to 5 years of age, and then again in adolescents. We do know that the risk for seizure disorder is proportional to the severity of the intellectual disability. Again, we do see sleep disturbances in these children and psychiatric comorbidities. 70% of these children will have at least one comorbid psychiatric condition. It could be either ADHD, depression, anxiety, or learning disorder. And 40% will have 2 or more. So what is the prognosis for these children? We know that poor outcomes are associated with lack of joint attention, which is the child's ability to communicate through nonverbal skills, so eye contact, smiling, or pointing. And so if that is not present by the age of 4 years, that is a poor prognostic factor. Also, the lack of functional speech by the age of 5 years and cognitive impairment. We know that better outcomes are associated with early interventions and being included with neurotypical peers. So the best setting for this would be a daycare or school. Overall, children with normal cognition and mild autistic symptoms have the best prognosis. Those with severe intellectual disability and severe autistic symptoms have the worst. And if you take cognition versus autism, you would choose for the cognition of that child to be normal versus autism, because the better the cognition, the better the prognosis. So the American Academy of Child and Adolescent Psychiatry came out with practice parameters for treatment and assessment of children. They published their first assessment in 1999. They've revised it multiple times, and they updated it most recently in February of 2014. They had reviewed a number of articles over the span of 20 years, and their parameters follow certain guidelines. So they're either clinical standards, clinical guidelines, clinical options, or not endorsed by the ACAP. So the first recommendation, the developmental assessment of young children and the psychiatric assessment of all children should routinely include questions about ASD symptomatology. So screening typically takes place at the pediatrician's office. That is mostly the first point of contact for kids. They also provide educational materials to the parents to help them know what to look out for. Also, the American Academy of Neurology has suggested an algorithm for screening, which is level 1 and a level 2. The level 1 is basically where every child receives a screen at a well-child visit, regardless of whether there are concerns regarding autism. And then a level 2 is where they receive more specific evaluations when there are concerns or a screening test has been positive. So I wanted to share some of the additional recommendations that was made by the American Academy of Neurology. They recommend that any child at a well-child visit should receive any one of the following, which is an autism screening questionnaire, a child developmental inventory, a parental evaluation of developmental status, or a Bridgens. They also recommend that any child with no babbling, pointing, or gesturing by 12 months, no single words by 16 months, no two-words spontaneous phrases by 24 months, and any loss of any language or social skill at any age requires immediate evaluation. So here's a table. The point that I wanted to make is that there are a number of screening tests out there, but they can be used by different people. Some are teacher rated, some are clinician rated, and some are parent rated. And so that helps to establish the dysfunction the child is having in multiple environmental settings. So recommendation number 2, if the screening indicates ASD symptomatology, a thorough diagnostic evaluation should be performed to determine the presence of ASD. So as a clinician, you would look for developmental screens which suggest the trend of developmental delays. Also history. In history, you're going to look for family history of ASD, any sort of change in the environment. So was there a change in the caretaker, change of schools or residence that could possibly cause the regression of the child manifest as ASD. We also look for collateral history. Just like we need multiple deficits in multiple environments suggested for ADHD children, we also require that for ASD children. And so we want to talk to as many people as possible to understand the difficulties that the child is having in different environments. Also look for past records, any sort of intervention or behavioral modifications that were tried, and if so, how did the child respond to it? Again, look for DSM-5 criteria. By the history you're getting, does this satisfy DSM-5 criteria? And lastly, direct observation of the child. So that brings us to recommendation number 3. If you have done your part of the evaluation and you are suspecting autism, the ACAP has the next recommendation, which is clinicians should coordinate an appropriate multidisciplinary assessment of children with ASD. So this means a medical evaluation, physical examination, audiology testing to rule out deafness, karyotyping, chromosomal microarray, and testing for the MECP2 gene if you're suspecting Rett's. Also consider neurological, endocrine, metabolic, and toxic etiology. You will need a neuropsychological assessment. This is to understand any sort of cognitive or adaptive skills deficits that may be present in the child. Typically for children with ASD, there will be a discrepancy between their cognition and functional adaptive skills. You'll also need a communication assessment and an occupational and physical therapy assessment to look for any motor or sensory abnormalities. So you were able to refer the child, and you've got all the history to suggest that this is an autistic disorder. And so here comes in the fourth recommendation. The clinician should help the family obtain appropriate evidence-based and structured clinical and behavioral interventions for children with ASD. The ACAP recommends that the primary mode of treatment for ASD is behavioral. One of the modes of that is applied behavioral analysis. This is a method of increasing the desired behaviors, using maladaptive behaviors, and teaching the children new skills that they can hopefully utilize to other settings. It is an early intensive behavioral intervention, and it requires at least 14 to 20 hours per week. I know that some of you in the audience might be experts on behavioral modifications, but for the sake of my fellow residents and medical students, I wanted to share briefly of this. So in that, you saw that she's using a lot of imitation and trying to draw the child's attention to her actively. So a modification of the ABA is the Early Start Denver model. This is a comprehensive behavioral intervention. It's delivered by parents and therapists. So the therapists typically train the parents over a period of weeks, and then the parents are able to administer this therapy at home to the children. It's a little bit different from the ABA in that it starts in the early years of the child's life. So they are less than 2.5 years old. And it's continued for a long period of time, so at least 2 years. Here again, they work on deficits in imitation, theory of mind, and social perception. And I also have a brief clip of that.
hours of therapy each week.
Where was Matthew's focus group?
Maybe unattached.
Routine, do you think?
The therapy combines several science-based practices for working with autism into one intervention program. So rather than analyzing just communication or eye contact, the ESDM model is designed to work on improving several skills at once.
So during the book routine, you saw me elicit eye contact. You saw me do vocal imitation with him. You saw me elicit sound effects with him with the slurping of the soup. Worm's eye.
I apologize for that mistake. So this was just a brief show of what the ESDM model is like. So the next mode of intervention for children with ASD is educational. The first method of educational intervention is the TEACH program, which is treatment and education of autistic and related communication handicapped children. And so we know that children with ASD have limited capacities for language, abstract and conceptual tasks. This makes verbal teaching less effective. And so the TEACH model employs a lot of hand and eye integration, and we try to get the child very much involved through the use of visual tools also. You'll find that classrooms that are arranged according to the TEACH concept are very clear in terms of the areas that are demarcated for either reading or other play activities. The next mode of intervention under educational is the Individualized Education plan. So this is basically a plan which is tailored individually for each child. It is keeping their deficits in mind and allows the child to be kept in the least restrictive setting. So that would typically be school with neurotypical peers. And so for any subjects in which they have impairment, they are given assistance. An extension of the Individualized Education Plan is the Individualized Transition Plan. Here, adolescents who require vocational and pre-vocational skills necessary for subsequent employment and independence are taught those things. Also, we use communication treatments, so they typically work with a speech pathologist. Children are also taught various social skills, so we use the concept of joint attention, and there are a number of social skills curriculums that are available for providers to refer to. The ACAP also recommends CBT, or cognitive behavioral therapy, as well as anger management for adolescent autistic children because they're typically very anxious, have difficulty with controlling their behavior, and also low frustration tolerance. Lastly, auditory integration training, sensory integration therapy, and massage therapy have not shown reliable results. Although you will find that some schools and some teachers do use this because it helps calm the child down in the immediate setting, which means that they can get the task completed. So, recommendation number 5. Once you've tried all the behavioral interventions possible, the ACAP suggests the consideration of pharmacotherapy. So pharmacotherapy may be offered to children with ASD when there is a specific target symptom or comorbid condition. So aggression, irritability, self-injurious behaviors, stereotypic behaviors, and maintaining the child in the least restrictive environment. This is always used in augmentation to other interventions, and we currently have 2 FDA-approved medications, risperidol and Abilify. I found a statement made by the American Academy of Pediatrics, which was in concurrence with what the ACAP suggests, and I wanted to read that out and share with you all today. They state, medications have not been proven to correct the core deficits of ASDs and are not the primary treatment. However, associated maladaptive behaviors or psychiatric comorbidities may interfere with educational progress, socialization, health, or safety and quality of life. These behaviors may be amenable to psychopharmacological intervention or, in some cases, treatment of underlying medical conditions causing or exacerbating the behaviors. Effective medication management may allow a child with an ASD to benefit more optimally from educational interventions. The AAP has also suggested a clinical approach to psychopharmacological management. They recommend identifying target behaviors and the patterns of it, noting available supports and how the child is responding to it. Any medical factors, so pain caused by an infection could also be a cause for the behavioral issues. Also note the level of impairment in academic, social, health, and quality of life settings. You want to be able to document that the response to interventions have been suboptimal and thereby support the use of your medication choice. Then you'll have to discuss with the parent regarding all the adverse drug effects. Subsequent monitoring of effects is also required, and you can consider withdrawal of the medication in 6 to 12 months to see if the child actually still needs them. So there were a number of studies for a number of different medications, but currently aripiprazole and risperidone have FDA approval. There were 2 studies for aripiprazole, both of which showed greater than 50% positive response compared to placebo. And then there were 3 studies on risperidone, which showed greater than 60% response compared to placebo. They've also studied SSRIs to see if they're indicated to help with the repetitive behaviors seen in ASD children. Celexa did not appear to show any significant improvement, but fluoxetine and clomipramine suggested that there can be improvement in children with repetitive behaviors. The next recommendation is recommendation number 6. The clinician should maintain an active role in long-term treatment planning and family support of the individual. So as the child is going to age, you're going to have to modify your services. If you have a very young child, you're focusing on diagnosing them and identifying optimal treatment plans. If you're a school-age child, you're going to look for modifying the behavioral issues so that they can function in various settings. And then for adolescent children, you want to give them pre-vocational and vocational training. Don't forget the parents and siblings. Support groups for the families are essential to help them get through this. So the last recommendation of the ACAP, clinicians should specifically inquire about the use of alternative and complementary treatments and be prepared to discuss their risk and potential benefits. Again, there has been a lot of literature on different types of treatments such as intravenous secretin, B6, magnesium, gluten-free or casein-free diets, and the ACAP does not support the use of any of these interventions currently. So when we went through the epidemiology, you might have been wondering about what is the trend of autism in Tennessee. And so I wanted to share a little bit about that with you today. So there is the 2012 state autism profile. And if you look at the table up here, you'll see that from ages 3 to 5, in the year of 2000, there were 153 children that were diagnosed with ASD. As of 2013, it's gone up to 831. And then you'll see a similar trend for all other age groups where there is at least 4 to 5 time increase in the prevalence rate. So to deal with this, the government of Tennessee has been trying to expand services. Currently, you can go to Tennessee Disability Pathfinder, and this is operated by the Tennessee Council on Developmental Disabilities and the Vanderbilt Kennedy Center. Through this website, you can access services, training, case management, and even a database of services based on which county you live in. You can also connect with the Regional Autism Society, which is the Autism Society of East Tennessee. In Tennessee, we have the Tennessee Early Intervention System, which is used to recognize children that are less than 2 years of age and at increased risk of autism. Subsequently, children in school do receive an individualized education plan. Sometimes they are accompanied with an autism consultant who can sort of tailor their plan according to their personal requirements. As of 2014, the Tennessee Autism Spectrum Disorder Task Force was created. They are making recommendations to the General Assembly for improving the diagnosis and services available to these children in our state. So in summary, autism is a neurodevelopmental disorder with phenotypically heterogeneous presentation seen in the early childhood period. The DSM-5 criteria has now brought all different diagnoses of autism under one umbrella, known as the autism spectrum disorder, and they advocate for thorough medical and environmental conditions to be considered within the diagnosis. The ACAP recommends thorough evaluations for medical causes. They noted that clinician diagnosis trumps screening tests, so you can't consider a screening test as a definitive indicator of the diagnosis of ASD. Behavioral interventions are the first line of treatment, and medications are adjunctive to behavioral intervention. Within Tennessee, we have seen a progressively increasing rate of autism. Resources have expanded to provide services, and regionally we also have the Autism Society of East Tennessee. So this was a brief list of some of my references, and special thanks to Dr. Martha Bird, Dr. Alan Musil, and Dr. Michelle Moser. And I'm almost done, but not quite done. During the preparation for today's presentation, I had the chance to be acquainted with Ms. Rhonda Marshall. Not only is she a psychiatric nurse for a number of years, she is also the parent of an autistic child, and she is here today to share some of her experiences and challenges in the process. So please welcome Ms. Rhonda Marshall.
Hello, thanks for having me today, and I was so excited when Stephanie called me and asked me if I would come, because anybody that will listen to me and my story of autism, I'm always there to tell it. My journey began 21 years ago. Zachary is my son, and basically we were not able to get an early diagnosis because 21 years ago, I just carried a child around that I knew something was different. Something was not right. I kept being told that I was comparing him to his sister, as in the autism world, as we refer to as his typical peer. And it took me to the age of 11 before Zachary was diagnosed. So I had some big time catching up to do on early intervention, would you say? We did it on fast forward. But as you're looking at your practices and stuff, one of the things that we have seen with our kids, and what I hear from experience with different parents, is that, of course, you have the sensory issues with the children that will be manifest a lot of times in irritability, agitation, things of that sort. The poor eye contact the children will have. If you have a kid that is not a good eater, I know in this day and time, Zachary would have been considered a failure to thrive child and probably would have had a G-tube, which scares me to death because in my other life, I do home health assessments for an unnamed insurance company, so you all won't throw stuff at me, okay? But what I see in that is, you know, we have just tons of kids that are getting G-tubes now. And a lot of times it's because they're poor feeders. And, you know, part of me is like, is that a sensory issue that nobody really thought to look at? Because Zachary weighed 13 pounds at 1 year. He weighed 6 pounds when he was born. After I quit breastfeeding, he didn't want anything. Didn't want to take a bottle, nothing. So had to get him on table food and things of that sort. Zachary also, at the age of 2, basically had a vocabulary of 5 words. Once again, I was told I was comparing him to his sister. Zachary never babbled, so that was an indicator to me also. But when I brought Zachary home, I knew something was wrong because there was nothing to satisfy him as far as he didn't want to be held. Just kind of wanted to be by himself. And I'm like, okay, you're an infant. You can't be by yourself. you got to have me interact here with you. So when he was 2, got him into speech therapy as an early intervention. Still didn't know what was going on. Finally, he entered the school system. Basically, Zachary's school career until we had a diagnosis, until he was about in the 5th grade, was basically how bad my child was. That's all I heard as a parent. You have a bad child. Of course, that makes you think you're a bad parent. But basically, it was a lot of the sensory issues in the classrooms, sitting, those sensory things that weren't being addressed. When he was diagnosed at 11, what I did as a parent is I found myself with support. My pediatrician was wonderful. Dr. Margaret Farmer, I will say her name. She was wonderful as far as working with us and helping us find someone to diagnose Zachary. But also as far as helping me as a parent to get involved with family organizations so that I could meet other families that could help cope and survive through this. In your practices, not only, I call these kids village kids, okay? Because it's not going to be just the parent and that kid. It's going to be the school. It's also going to be any kind of extracurricular activities that kid's involved in. It's going to be the pediatrician. It's going to be the neurologist. It's going to be the gastric guy. It takes a whole village to work together to raise these kids. Also, with Zachary, he also had a learning disability also with reading, as Stephanie was saying, was a co-occurring incident also. When Zachary was first diagnosed, prior to that, we had diagnosis of ADHD, OCD, anxiety. So when you have a kid that comes to you that you see that have had all of these different diagnoses, you know, I want you to put in your mind, you probably need to think autism, because those are all different symptoms that are manifested by the disorder. So kind of keep that in the back of your mind. Early screening is going to be the key to success for our individuals, with occupational therapy, who will help us deal with those sensory issues that the person has. Speech therapy. It's not so much a speech disorder with a lot of our kids, but language, okay? Language is what we need to work on, those pragmatic skills, how to interact with people. Some of our kids, physical therapy is indicated because our kids are a little klutzy, and they do lack some fine motor skills. I know that one of the keys when Zachary started school is that he could not hold a pencil, not even the big pencils. But they were going to go ahead and pass him from kindergarten to 1st grade. I was like, no, we need to look here. We need to back up a little bit with that. But your intervention with the school system is going to be very, very important. I know that we finally had to go to North Carolina to be diagnosed. In the state of Tennessee, if you're lucky to live in Nashville or Chattanooga. In my opinion as a parent, if you have a child on the spectrum, those are two of the best cities to be in right now that have a lot of intervention services. We still have a long way to go in this area. We do not have a centralized diagnostic clinic for autism or services. And you would think Knoxville, as large as Knoxville is, would have a centralized place to get that done. But they don't have it. You know, so as parents, we kind of scramble here and there. We work together to find out where the best services are. And that's where we tend to get the best information in this area, is from our other parents and who is going for treatment where and what is working. As Stephanie is talking about, where they have changed the diagnostic criteria, and it is autism spectrum disorder, okay? Once you meet one autistic kid, you've met one autistic kid. They're all different. There is nothing cookie cutter about treating an autistic kid. Each one is individual. Let me go back to educational again. It's so important. Now that I'm kind of considered the grandma or the elder of a lot of the parents around here, since I do have an older child. But with educationally wise, I had to actually move Zachary up a year in school in order for him to get accommodations to get a regular diploma when he graduated. Was just absolutely lucky to have a nephew that worked at a grocery store who was able to get Zachary employed at a grocery store, which was great because a lot of our kids with the repetitiveness, he stocks shelves at the grocery store, so he has the repetitiveness. He has the feeding in of his OCD. Everything has to be straight and perfect. I hate to take him to the grocery store with me because if I don't go to the one he works at, he tells me how horrible the stockers are there because they don't do it the way Zachary does it. But that's one of the things with the OCD-ness, and these kids, they will tell you that's what it looks like. It has to be a certain way for it to look balanced for them, is why they do a lot of the OCD stuff. Can you all tell me how much percent of adult children on the young adults on the autism spectrum actually are employed? Take a guess. %. People on the autism spectrum, a lot of them are very bright. One of the main reasons we see so much problems with behaviors and stuff is because of communication issues. One of the number one reasons home health is ordered for kids right now is because they are autistic. Parents don't know what to do. So they're like, okay, we'll get home health in here. Well, you know, there's good things and bad things about that, because if you get somebody who doesn't understand the autism spectrum, it could make your problem much worse. But, you know, one of the things also is that as an adult, the state of Tennessee Teen Care will pay for an aide to actually go help adults in a work situation. I don't utilize that in Zachary's situation, but they are able, Teen Care is able to do that. Also, Teen Care can, with our youth, they can actually help with sending that aid to a daycare, because integrating our folks early as we can into the typical population for them to learn those appropriate behaviors is going to be great as far as that goes. So keep that in your mind. Also, Teen Care will pay for ABA therapy in the home if that needs to be done. My thoughts on ABA is you got to get the whole village. If you're just going into the home and working with the parent and not working with the school, it's a disaster. And I do see that happen a lot. So you got to be working with everybody. Applied behavioral analysis, I'm sorry. Michelle had, I'm sorry, Stephanie had made a reference to that because ABA is sort of a basic gold standard for dealing with behaviors. But I am a firm believer as I go into homes and I see children and young adults on the autism spectrum, they have totally been neglected on ways to communicate. And I think we wouldn't have to use half as much medicine in interventions if we could teach our families and our kids how to self-regulate with those behaviors. It's very, very important. There are lots of, Stephanie had made reference to, and I'm trying not to say names of different organizations, that locally we do have interactions for family members. We have, talking about repetitive interest with our kids, Legos. If you don't know Legos and dinosaurs, a lot of times you can't talk to our kids. And use those special interests to your advantage by, even in the educational system, altering and modifying different situations with whatever their special interests are. But we do have like a Lego club here locally that we have typical and atypical youth that they interact together over Legos. Also, we have a support group in Kingsport that we bring speakers in. We are actually having a conference here in Johnson City. The 14th at Muncie Memorial. Please come if you all can. I'm going to give this back to Stephanie. If you all have any questions for me, please let me know. I am a parent contact in the area that if you all need to get in contact with me, you can contact Stephanie and she can get you with me because in your practice at the point of entry, getting those parents hooked up with other parents is going to be a key for success for our kids on the spectrum. So, can you hold my arm?
Just before questions, as I know some people may have to leave as we approach 12, the code I have figured out if they're still eligible to call in, the main number 423-200-3259, the 5-digit code is 65013, that's 65013. And I hate to distract, I just know that some of you all may have to leave as we approach 12.
Thank you, Ms. Marshall. As Ms. Marshall indicated, we're open for any questions. Yes, Dr. Shah.
I wanted to comment just on a few things.
Sure.
First of all, I think the diagnostic criteria don't do justice to the ways in which these kids can present and the unique kinds of problems that they can present. To illustrate, I was involved with a case in which, as part of the spectrum of repetitive behaviors, an early adolescent decided it was interesting to insert and remove objects from his rectum. And to the point of actually prolapsing his bowel. And call exempt from ERISA. Tennessee Eastman does not have to provide coverage for anything related to autism, and in fact it's an exclusion from their coverage. So I consulted with a family that works at Eastman who needed services for their child, and the way that they got around it was to not use the term autism, but instead to seek treatment only for the comorbid condition of anxiety. If anxiety was on the claim form, they would pay. If autism was on the claim form, they wouldn't. So you have to know whether your patients fall into one of those gaps, because, you know, in a very well-meaning way, you can put down the core diagnosis, shut the person out from being able to get treatment at all.
Absolutely. The clinician that diagnosed Zachary in Asheville, the computer program she had automatically, if ADHD shot out, ODD did too. And she did not understand. I told her, I said, you know, if you think my child's oppositional defiant, fine. But if you don't, this is going to kill me in the educational realm of things for my child. And as far as the insurance companies go, and I'm not, well, we won't even say I said that earlier about the insurance company that I work for. But anyway, you appeal, appeal, appeal. You contact your legislators, the Tennessee Justice Center. There's lots of ways to advocate and get things changed as far as that goes as a parent.
Yes, Dr. Miller?
I want to commend you on an excellent presentation and to ask you, do you have, from your reading, ideas or theories on why the incidence has increased so much?
And that's somewhat what the literature suggested, which was what I went through was the diagnostic substitution, you know. So if children could qualify for services under the diagnosis of autism, then they would give them that diagnosis. Whereas previously, AD did not qualify, and so they would have to substitute with, say, either mental retardation or learning disorder. Also, you know, funding trends, parents trying to ask for a diagnosis, and also what the trend has been in terms of institutionalization. And so there's been a huge move to close institutions and to move these children back into their homes with their parents. So they're attending community or public schools, and they're being quote-unquote counted in the educational prevalence data.
So it may or may not be a real change.
Yeah, I think that's partially what some of the theories are suggesting, if not completely. Yes, Dr. Chandra. So far, I could not find any data on the prevalence rate based on DSM-5 criteria, and as far as I'm aware, even the state of Tennessee has not started using the DSM-5, so I just couldn't find any data. Everything that I had today was based on DSM-4, but yeah, I think that would be a valid concern.
Nationally, it's 1 in 68 children right now.
Yes, Dr. Agarwal. Sure.
I'm all about the monitoring, would suggest that there's a disconnection between what an autistic kid sees and what they're hearing. It's like in your video, and presenting an object that car. Maybe the child is not hearing what she's
Yeah.
saying, and there's a process of that. So, and this speaks to a lot of the learning and other kinds of communication abilities. So what I would say is that perhaps we don't really have a good definition of it. And I would say we're able to properly diagnose it and see that determine within vision autism, recognize it.
Sure. Thank you so much for pointing that out. Yes, Dr. Henry.
Certain soft signs, especially associated with ideovisceral motor skills, are very interesting in the illness. For instance, a lot of autistic children will script and use scripting in order to avoid having to develop spontaneous language utterances. They often will have similar kinds of things happening in other sensory fields. For instance, tactile perception. A lot of times they won't like to be held, but they will like very much to be gently rubbed. And, they are odd things, and I think that whenever you talk about theory of mind, you think about mirror neurons. In the human, the connection between mirror neurons and the insular frontal lobe probably are heavily connected with the nature of what theory of mind is. And it's interesting because in that triad of emotion, appraisal, feelings that people tend to have, it's like the emotion unconsciously arrives, and then often the appraisal portion involves mirror neuron connections in the brain. But in autism, it appears to be that emotional drive isn't the same, though kids with autism should be taught appraisal skills so that they can approximate the same kinds of feelings that others have. And it's an interesting process. Often why it is that autism, as they proceed into adulthood, become more and more mainstream because they have learned those skills even though they didn't instinctually exist early on.
And I tell that to parents all the time that has higher functioning children. It does get better if you can survive puberty, which is typical with all teens, but it's a little bit challenging, like Dr. Shah was saying, some of the different things that may come up. But yes, I think I totally agree. With those coping skills, they do get them, they have them there, they just may not come out age appropriately.
Well, my mildly autistic grandson is 12, so thank you for that comment about
I promise, it will get better. You're good, that's it. And it may be sweating for a few years, okay, but 17 is kind of a clicky age. It was for mine.
Yes, Dr. Shah.
I'd like to make a follow-up comment also on part of the presentation that dealt with medication. 2 points. One is, I think it's important to keep in mind that the literature doesn't necessarily address the full spectrum of target symptoms in a particular case. For example, you cited a study about citalopram being ineffective for repetitive behavior, but I've seen citalopram be extremely effective for anxiety. So
Yeah.
we need to look very carefully at what exactly the literature talks about. The second thing is that with respect to some of the complementary and alternative you mentioned, I think it's important to remember that these children can, like anybody else, still respond to placebo, and that can be a useful behavioral intervention. Again, case in point, I know of a family in which a young child goes to his mother on his own and says, I need my calm down juice. And she gives him a drink whose active ingredient is magnesium. The literature you cited says not effective, but mother says it works. Now, if it's nothing more than a behavioral ritual that helps this child access his
Thank you for pointing that out.
And I know one of the organizations I deal with, I mean, there are lots of families that do lots of odd things, and medically I kind of shake my head, but you know, if it works for that family and it works for that kid and helps them progress and it's not hurting anybody, then there you go. You have to respect that. And
Sure. Sure. Yeah. So if you go through DSM-5, what they state is that if a child has intellectual disability, you have to look for a discrepancy between the social interactions and the ability to maintain social interactions for that particular age. So even if they have intellectual disability, for that mental age, they are supposed to have certain social skills. And so children with ASD will lack that. Any other questions?
I have a question for Dr. Shah. As far as, I know a lot of our kids do not traditionally test well with like the school IQ test. We know that they're much more functional than what the numbers give us on the IQ test. Is there any way to get a true IQ or any new testing that's out to address that?
Well, a test is simply something that you give at one point in time, a snapshot. And if you have a kid on the autistic spectrum, particularly one who's got communicative difficulties, so they may have difficulty understanding instructions to the test, or they're locked into needs for sameness, so the fact that the test is something new disrupts them, you're just not going to get valid results out of that one thing. And it's not that there's anything wrong with the test, it's just that the kid cannot engage with the test appropriately because of their condition. So the way to get around that is by doing things longitudinally and more slowly. If I was working in a school setting, for example, I might spend a bunch of time developing a relationship with the child so that I'm not a new frightened person. And then I might do one subtest of the test per day over a period of 2 weeks. So I don't overwhelm the child. It wouldn't be a perfect standardized administration, but it would be an administration intended to get the optimum functioning out of this kid.
Thank you. That's a great idea. Thank you.
I'm not aware of anything particular. I know that in speaking with Rhonda, she had mentioned some concern that sometimes, so if you, based on DSM-5 criteria, if the child were to retest and if they didn't qualify for autism spectrum disorder, what would happen then? Would they lose services? So I think that has been a concern from the parent side, but no, I'm not aware of anything else at the moment.
And there was a point of discussion I had with Dr.
It's acceptable.
Exactly, that's why I was asking.
So what happened was that many, that's the vision is that many people with autistic deficits start getting diagnosed with what they have is what a spectrum. They are a little bit on a poorer side of the skills, not including have autistic issues. So when I attended the DSM-5 APA in 2013, that is what they were talking about. They want to make sure that the boys don't do any autistic people who use for any of the social skills that they get diagnosed with as
In, you know, in a parent's role, like Stephanie had said, it's very important to have that diagnosis as far as to access services. And there have been a lot of parents that have been afraid that if they retest, they will lose services. Because, I mean, you have to look at the big picture. Like I was saying with the ODD diagnosis, that's not going to get my kid or anybody's kid anything. Autism, as far as services they need to intervene, looking at disability, looking at, vocational rehab, things of that sort that you look at for the future. But as parents, when we get together, I mean, we focus on our kids' abilities. We don't call them, we just learn differently is how we speak of it. My son to this day, because he has done better with aging. He's like, I outgrew that autism. Well, you're right, Zach. So we'll deal with those special ability issues that come up as they go. That's just how we discuss it. So, but I think it's really important because parents decide, a lot of times they'll say, do I tell my child or do I not? Well, our kids are huge targets for bullies, and, to know that we just learn things a little bit differently and explain that to them that way, lets them know that they do have some things to work on at times.
Any other questions?
I'd like to follow up on some of my answers to your question about testing, because there's something else that was sort of a political issue. Let's say you wanted to get an IQ test on kids, and you're going to have it paid for by insurance. Insurance will pay you for an hour and a half to 2 hours of your time to do that, and then you expect it to be done. In contrast, if you were in Israel, following an approach recommended by a fellow there named Reuben Feuerstein called Dynamic Assessment, what you would do is you would give the child a task, you would measure where they are, and then you would engage in experimental intervention to teach them and see how far you can move them along. Feuerstein's argument is that measuring where the child is at is not the most important information. The most important information is what can we do to change where the child is at. And so he would argue that a proper assessment needs to include trial intervention to see if you can move the child beyond what their original score on the test was. That's way more time consuming. People don't do that in this country because insurance companies don't recognize it as a person. So the only place you're going to get that kind of assessment done is in a tertiary center or a specialized developmental disability center.
Absolutely.
Maybe like Kennedy Center at Vanderbilt or Johns Hopkins or someplace like that.
Absolutely. Absolutely. Tell Rita I said hello, please.
Thank you so much.